Week 14 of Aon's Public Affairs podcast was recorded July 8th, 2020.
Hello and welcome to the Aon's Public Affairs podcast. Daniel Serota, Public Affairs out of Chicago, Illinois. Well, I am excited to be joined by my older brother, Stephen Serota, president of Wisconsin Diagnostics Laboratories, and Dr. Stephen Kroft, who is the chair of pathology at the Medical College of Wisconsin. Dr. Stephen Kroft, Steve, welcome to the podcast.
Thank you, Daniel.
Hey, Dan. Thanks.
So let's dig in here. There's a lot of stuff happening. We're in a global pandemic. You guys have been extremely busy working for the state of Wisconsin and being part of the laboratory ecosystem there. One of the big things that our clients are seeing, but all across the globe are seeing, is around testing. The increased number of cases, the increases all across. We see it locally in Chicago here, but Milwaukee too, with the different orders that have been taking fold over the past couple of months. Guys, I would love for you, maybe Dr. Kroft, to kick it off, to talk a little bit about the testing overall and what type of tests are out there.
Yes, absolutely, Daniel. So there's really two main classes of COVID testing. The test that most people are referring to when they talk about getting a COVID test is a test based on a viral nucleic acid, in this case, RNA, that's present due to replicating virus in the upper respiratory tract, in your nose, in your throat, in your lungs. And when you go to get one of these COVID tests, it requires usually a swab of one of these locations. Typically, to date, it's been what we call a nasopharyngeal swab, which is similar to what you'd get if you wanted a flu test. This represents essentially the gold standard for diagnosing someone who has an infection now. It is ultimately based on finding the RNA, amplifying it, and detecting it in one of a number of test systems. The gold standard for this is a test that was developed very early on in the pandemic by the CDC. And since then, we have a number of commercial vendors who have developed testing that works on various instrument platforms in laboratories like ours. So when we call it the gold standard, what we are saying is it is the recognized means of diagnosing someone who has an active infection in the respiratory tract. It doesn't mean it's perfect, though. Even the best tests, again, the CDC test or equivalent tests, do not pick up every single active infection. And that's really important, I think, for both patients as well as other healthcare professionals and the public to understand. For someone who has symptoms, who walks into their doctor's office with the symptoms and gets tested, probably a single test in the nasopharynx with a swab is going to pick up about 90 to 95% of infections. So if someone is exhibiting classical symptoms of COVID and they test negative once, it's really important to test again because no single test is perfect. Now, you're most likely to have a positive result early on in your symptoms. So when you first present with symptoms, and over time as you recover, the amount of virus goes down and therefore the sensitivity of the tests also goes down. So your best bet is when you initially present with symptoms. As I mentioned, not all of the tests perform equivalently, although the majority are in a similar sensitivity range in terms of 90 to 95%. So that is the COVID test that we're all referring to. Now, it's worth mentioning that the nasopharyngeal swab is a bit uncomfortable, and many laboratories, including our own, are actively looking at ways to make it less invasive. So instead of the far back in the nose swab, maybe in the front of the nose, or even saliva or another site. And while these are more palatable for a patient, any of these sites are going to come with decreased sensitivity. And the last thing I would mention about the nucleic acid-based COVID test is when we're talking about asymptomatic patients, we have a little less certainty at the present time as to the sensitivity of the gold standard testing. However, we have reason to believe that when you're asymptomatic, but you have the virus, the sensitivity of the test, in other words, the likelihood of a single test picking it up, probably down in the range of 80 to 85% instead of 90 to 95%. So again, underscoring that a single negative test result under any circumstances does not entirely rule out the virus. So that's the nucleic acid test. It's a very good test from our standpoint in the laboratory. It works well. It's positive. It's definitely positive. It doesn't cross-react with other viruses, things like that. Now, the second major class of testing, which there certainly has been a lot of public press about, is antibody testing. Antibody testing serves an entirely different purpose than nucleic acid testing. So what antibody testing is looking for is the presence of your own immune response to the virus, rather than the virus itself. It is not suitable for diagnosing an active infection because it actually takes probably an average of 10 days from symptoms to actual development of antibodies to the virus. And it's a blood test, by the way, rather than a swab. So unless you're afraid of needles, it's actually probably better tolerated than the nasopharyngeal swab in many circumstances. What the antibody test tells us is whether you had it, or in some circumstances, you can still have it, but also have antibodies. But for the most part, what the antibody test is telling you is you have been exposed to the virus at some point. So from that standpoint, a lot of people are interested in antibody tests because a lot of people in the last 3 months have had some symptoms that make them think maybe they had COVID, but never got tested, and they're interested in whether they were exposed and therefore maybe have antibodies that makes them immune to infection. So that is the main application of antibody testing. It has some significant caveats that come along with it. Really important caveat is we don't yet know with certainty how protective the antibodies are against repeat infection. This is extremely important because we don't want people to believe that by virtue of having been exposed or having antibodies, they're absolutely immune and become reckless in terms of their interactions with their environment, social distancing, masking, etc. The body of evidence that is accumulating is that there is likely at least some degree of immunity for some period of time, perhaps 3 months, perhaps 6 months, perhaps longer. And we'll find out more as our understanding of this pandemic evolves.
Steve, Serota, what do you think is some common misunderstandings on these tests that Dr. Kroft is kind of talking about here?
Yeah, so I think it's really important to note that as we talk about any kind of testing, the most essential sub-elements of that is that you get an accurate and appropriate result to the test. And COVID testing, like a number of different types of testing, as folks started to roll out methodologies, not all of them are created equal. And Dr. Kroft alluded to the gold standard that we utilize at WDL. WDL, Wisconsin Diagnostic Laboratories, has always focused ourselves on providing clinical excellence because we believe that a wrong test is much more damaging than no test at all. So making sure that the testing methodologies that the labs you are utilizing have strong sensitivity and specificity to the specific question being asked is really essential for a patient to get accurate results. A number of the rapid tests that were originally rolled out had very, very low levels of sensitivity. And as a result of that, you got a lot of folks who were getting both false positives and false negatives, which, as you can imagine, creates a real clinical issue because people aren't actively able to respond appropriately to those results.
And from your point of view, Steve, just digging it a little bit farther, what are some of the most important information for a person to understand when they are getting that test? What should they know moving forward?
I think it's really important to understand what methodology your doctor or the lab you're using is actually using to perform that test. There are a number of incredibly good tests out there in the marketplace, and there are a number of incredibly bad tests. And it's really important that individuals educate themselves on the actual testing that's being performed. You can draw a direct correlation to that to flu testing. When we were all younger and used to go get flu testing with the first generation rapid flu test, it was essentially like flipping a coin. The accuracy was not very good. And what most of us used to see as kids is you'd go get a flu test, you'd be negative. Then they'd send that test out to a laboratory and you get a call, actually it's positive. And the same thing can actually happen with COVID. And if people are making clinical choices, i.e. self-quarantining, i.e. wearing masks or other such things, based on a test that is inaccurate, that's incredibly dangerous from a public health perspective.
So if I may jump in, a technical aspect taking off from what Steve just mentioned related to antibody tests. We've seen a lot of press about how antibody tests are inaccurate. In fact, the tests that are in primary usage in laboratories like our own are actually incredibly accurate. They're very, very good tests. They have very high sensitivity once you get out about 14 days from infection, and they have very high specificity in the range of 99.2 to 99.8%. What that means is that if you test 1,000 people who don't have any exposure to the virus. 992 results will be negative, and 8 out of those 1,000 will be positive. And that sounds fantastic. The problem is, if the prevalence of the virus, meaning the number of people in a population, is very low, which is still the case in many parts of the country, even with an outstanding specificity like that, you still have a high frequency of false positives. And this relates probably largely to the fact that the coronavirus is related to very common viruses in the population that are associated with common colds. So a lot of people have seen these viruses, and there is a very low level of cross-reactivity. So it's important to understand that even good tests can perform badly in real-world circumstances. But again, I would emphasize that a positive antibody test, evidence of previous exposure, should not lead to a sense of security that you're immune and that you don't have to worry anymore about observing reasonable social distancing and masking protocols.
And that's extremely helpful to note, Dr. Kroft, because I think, the misconception is if you have the antibody test, you're like good to go, right? And you don't need to worry. But, to your point, you still need to be a little bit cautious. And I think that's important for, our listeners to really have a good understanding of that as well. And Steve, I'll throw you a question of how do you feel the access of testing has gone to really influence the communities, specifically Wisconsin in your case, but the response to COVID?
Yeah. So I think it's really important to understand laboratories' role in public health. We as an industry are really the first to know and to see when things like pandemics come to the market. And it is really essential that we're able to give people appropriate, timely, accurate information so we can make the best clinical choices. In this specific instance, this was a new novel virus, and as a result, new novel diagnostics needed to be developed to do this. At WDL, really, we have a phenomenal team of molecular biologists and microbiologists and physician partners who identified this as a real concern really as early as mid-March and quested to develop a test as quickly as absolutely possible. We actually, from decision to build the test to implementation, were able to bring the test up in less than 7 days and have accurately been able to provide services to the greater Milwaukee area as well as to clients as far as Indiana and Illinois, been able to provide that testing all the way through. The challenge that really most laboratories ran into, and WDL did as well, was an access to durable supply chain. So folks weren't anticipating the overarching need for this quantity of testing. And as a result, a number of the major manufacturers weren't able to keep up with the pressing demand for this specific reagents associated with this testing. What WDL did is actually went to a diversified model. We actually brought up a number of different platforms to ensure we created a durable supply chain to make sure that our patients always got the care that they needed. In addition to that, we focused on rapid turnaround time. One of the things that you probably heard pretty prevalent in the marketplace is these 5 to 7 day turnaround times that folks are experiencing. And that really puts people in a very challenging position. They know they have these symptoms, they've gotten this testing, and now they live in limbo for 5 to 7 days. Hopefully, folks are taking that proactive response to self-quarantine. But we know from other conditions and other instances of disease progressions that folks, unless they are given an appropriate and accurate diagnosis, often don't follow the same clinical guidelines. So when we developed our testing methodology, we did so in a way that ensured very rapid same-day turnaround time. We've actually been able to maintain a under 7-hour turnaround time for all of our clients. And this is so important because what it allows us to do is it allows us to empower our clinical partners as well as patients to make the best possible decision on how to handle the results of that test. What it allowed for Froedtert Health as one of our core partners is as folks came into the emergency department, they were able to appropriately determine whether or not those individuals needed isolation, whether they needed advanced support, and that way we were able to more appropriately utilize the resources available to service our community. So I think those things are really, really important. And as this pandemic continues to grow, you will see the lab industry continue to expand the ability to test accurately and to improve turnaround time. But one of the areas that really needs to be recognized here is the importance of localized and community laboratories. Localized and community laboratories have the ability, because of access to the specimens and geographic alignment with those people they serve, have the ability to turn these tests around even faster than commercial laboratories. And as a result, people are able to make quicker decisions about their clinical care. So I think if we've learned one lesson from the entire rollout of testing around COVID, it's the importance of having really strong community laboratory partners who are empowered and capable of providing accurate and timely diagnosis to patients.
So, Steve, I'll throw you over another question. One of the big things we're seeing in the headlines is increased number of cases. There was a big debate in the beginning about capacity of testing. What is the national scene on that now?
Yeah, we are still running into an issue where demand does exceed capacity. While it is not true capacity, as most laboratories are not running at 100% capacity to date, what we are seeing is pockets of extreme need and challenges with getting the right testing resources in the right places at the right time. It's really essential to have that strong turnaround time, that immediacy, so folks can make appropriate clinical decisions. We are, as an industry, as a laboratory industry as a whole, we are continually working to ramp up and expand the diversity of methodologies that are available. One of the major new methodologies that is starting to come out, and there's a bunch of literature on it right now, is the ability of pooling testing, which has the ability to potentially logarithmically increase the total capacity of testing within the industry. Dr. Kroft, would you mind giving us a little 2 minutes on what pooled testing actually means?
So the idea behind pooled testing is that instead of testing every patient's sample individually in its own little well, as we call it in a testing methodology, you basically mix together 5 or perhaps a few more samples together. You mix it all up and you test the mixture. And if the mixture is negative, then you can assuming you've done your validations of this methodology correctly, that everyone who you put into the mix is also negative. If the mix comes up positive, then you have to go back and individually test each patient's sample to see who in that group tested positive. But ultimately, in the right settings, this can increase testing capacity, as Steve mentioned, 5 to 10-fold, particularly in asymptomatic screening protocols. And really, that's where we're being challenged now. It's not so much in the managing symptomatic patients, at least in our community and in many communities across the country, although, of course, there are new hotspots. But the increased demand for testing large numbers of asymptomatic patients, as we discussed earlier in the context of reopening schools or businesses, is really what's challenging the industry with respect to keeping up with testing demand.
Well, look, I want to say thank you, Dr. Kroft, Steve, for jumping on the horn today and really digging in on the testing side. I think this was extremely helpful and something that will be a continued conversation. And I hope we can have you both back, at the end of the next couple of quarters to then dig in a little bit further of how everything has been going, because I don't think this is going away anytime soon. And we need to make sure people are informed and updated on how testing is going to play. So Dr. Kroft, Steve, thanks for coming on to the podcast.
My pleasure.
Yeah, thank you, Dan, and thank you for hosting this. I think it's really important to get this information out. So we very much appreciate the opportunity.
Thanks for joining and look forward to talking to you next week.
This information is a resource for Aon clients and business partners. It is intended to provide general guidance of potential exposures and is not intended to provide legal, regulatory, or medical advice. Due to the dynamic nature of infectious diseases, Aon cannot be held liable for the guidance provided. We encourage listeners to seek additional information from credible sources. Thank you.